And it was so fantastic to hear the environment that Judith's created there, the supportive environment that really helps people flourish and live well with cancer, in spite of their diagnosis. And it should be something that, ideally would be offered to every patient with a cancer diagnosis. So our next speaker is Professor May Krishnasamy. She's a Professor of Cancer Nursing at the University of Melbourne and lead for nursing at the VCCC Alliance and an Honorary Research Fellow at the Peter MacCallum Cancer Centre. She leads a program of nurse-led research that has been translated into health policy. It focuses on supportive care, equity of access, and experiences and outcomes for older people with cancer. Please welcome Professor Krishnasamy.
Thank you very much. It's an absolute pleasure to be here. Christine and the crowd at RCA, thank you so much for the invite. It's an absolute privilege. But I'd really like to start by acknowledging Natalie and Kevin and TJ, if I may. What an absolute privilege to stand here after you and to try and do some sort of justice to the experience that you've had. So when I spoke with Christine and Sarah and the team here, they said, we've given you a title, it's What's the Point in Asking? Experience as a Catalyst for Change. And so what I'm trying to do after this remarkable day and hearing so much is just pull some threads together. And if I could, I'd put this aside and just leave it because my thinking has changed since first thing this morning. But really think about what have we heard? What is indeed the point of asking? What are we trying to achieve? And how do we harness the remarkable experience that we've heard today, both from the most important people in the room as people with lived experience, but the remarkable science that's happening around people. So I want to start with this. I think we've heard a lot today about the challenges of navigating a system that is complex, that is challenging, that is inequitable. And that's if you're affluent, English-speaking, residing close to Judith's services. And one of the things that I want to talk about later in the talk is what happens if you're not one of those people. This is the reality for most people. Just a quick personal aside, when my dad had pancreatic cancer and died from it, I remember thinking, what do people do if they don't understand how the system works? If you can't be a harpy in the system and go, I need this, I need this, I need this, and my dad wants to die at home, that's what we're going to do. I need the stuff, I need it today, and we're going home. What happens to people who have no idea how to get through this mess and actually get what they need? And we've heard some of the consequences of that today. And I want to go back to Christine's quote at the beginning of the Rare Cancer Moonshot. Every day, both at RCA and for those of us who are privileged to work with patients and carers up and down the country, hear that navigating this system can be as really complex as it is uncompassionate. And I think putting people who are reeling from a diagnosis of cancer, let alone a diagnosis of rare and less common cancers, into that kind of system is uncompassionate at its best. We know that it doesn't work, and we know, and we've heard earlier today, and it's in the report, that a failure to act is a choice. Over the last 35 years, we've had 16 reviews of the complexity of the Australian cancer system, health system. The result, it says, is less an Australian health system than a complex set of services with multiple providers and multiple players, generating complexity for both patients and those of us in the system who are trying to navigate people through and make sure they have the best of experiences and the best of outcomes. Failure to change is a choice. We've known for 35 years that the system isn't working for people. So why do we ask? Because we know it's not working, and we've heard a lot today about the real challenge of taking remarkable science and advances and getting them into practice. We know that only a fraction of the work that's done from a research perspective gets into usual care, and that can take around 17 years. then, it's a real challenge. This is old data. This is not new news. And it's costly, and we've heard that already today. So this data from the US, $200 billion spent on healthcare research, 85% of which is wasted because it doesn't get to the people who need it to work for them. Not the patients, not the carers, and not the clinicians. If we think about transposing that 85% to what's spent on health research here in Australia, you can see this is data back in 2021, an estimated $6.9 billion spent on health and medical research. If we think that 85% of that doesn't get to the people who need it, that's around 600 million Australian dollars that we've spent and hasn't benefited anybody. So we ask because things aren't working, but we also act and ask because we've heard today over and over again the system is not equitable. This is Tudor Hart back in 1971 in the UK who talked about the inverse care law. The more likely you are to need help, the less likely you are to get it. And we've heard that today in so many ways. The more likely you are to need help from having a rare and less common cancer, there are many examples of the case where you're less likely to get the help than somebody who has a treatable cancer. Now, we know what the economics are around that. We know it's about big numbers. We know that things tend to get funded because they are big, prevalent problems. But I think, and Judith pulled it out beautifully, the burden of disease is immeasurable when you look at it at a person-centred level. So I love this quote. This was a remarkable palliative care physician who said something to me a very long time ago with the tongue so far in his cheek. He said, he said, when all else fails, just ask the patient. And I think, we've heard, and it's in the report, and we've heard today, that actually not listening and not asking people means that we fail in delivering what people deserve. Not including the voice of patients and carers is not an option. It's not an optional extra. It's something that should be driving and informing the way we think about transformation of the health system. 35 years we've known it's too complex. It's time to act. And if I could sing, even though I'm a Welsh girl, and I won't do that to you, there's a little bit of Elvis around, a little less contemplation and a bit more action, please. I'm really lucky. I want to spend the last 10 minutes talking about some of the work that I've been lucky enough to lead and do, informed by, in partnership with remarkable people with lived experience, whether they're patients or carers. This is just some of the people I'm lucky to work with. We're a mixture of doctors, allied health staff, health service researchers, policymakers, and, of course, people with lived experience. And I'm going to try and pick up some of the threads of the things we've heard today in the context of some of the work I want to talk about. I want to start with a programme of work called the NEAT studies. NEAT stands for the Nursing Equity Assessment Tool. And when I talk about nursing and nurse-led, I don't mean in a uni-professional lens. I think about the fact that we are the largest workforce across the health system. We need to be mobilised to get people to the multidisciplinary expertise that they need. And we have a huge opportunity to do that. So the NEAT system started many years ago on the smell of an oily rag when we had $3,000 from the Cancer Nurses Society of Australia. And we went out and asked 100 cancer nurses, what makes a person who has a diagnosis of cancer really complex to care for? What are the things that we need to understand so that we can think about how do we get to those people and how do we make sure they get the help that they need? And so we had the care complexity study. We ended up, I won't go into details, we've written about it, but we ended up with a checklist that had a list of things that these remarkable 100 nurses across the country were saying that were created flags in their mind. They thought, this person's going to end up in strife. This is not going to go well. I really need to think about some stuff early here. We did some hypothetical testing of the checklist, but when we looked at it, and none of you will be surprised to hear this, what we saw very clearly was that this was about social determinants of health needs. Your cancer's complex, but actually you might be coming into a system where you already have mental health issues, you're isolated, you're poor, you have domestic violence issues, you have drug use issues or issues of dependency on alcohol, whatever they may be. Things that put you so far on the back foot even before you've had your cancer diagnosis. And so the conversation that we had as a team was, well, how do you find those people quickly before you start making treatment decisions? And I'll come to that point about equity and equality in a bit. How do you get support to those people so we don't let them fall and crash in a heap halfway through and go, oh, poop, we should have seen that coming sooner? So the NEAT tool has gone through a series of studies, and I'll just quickly touch on those. We finished the care complexity, we got the checklist. We worked with staff at the MacCallum Cancer Centre and patients in their care and got them to test the nursing equity assessment tool for clinical utility. Is it acceptable? Is it appropriate? Is it practical? There's nothing scarier than looking at a room of nurses and say, I've got another form for you to fill in. You know, you take your life in your hands. But anyway, the data was great. We had really great utility data. But of course, when we looked at the characteristics of the patients and the carers who'd taken part, they were English-speaking, they were in the middle of a large metropolitan, excellent comprehensive cancer centre, that all the services around them. And so we realised actually that we'd missed the boat. And so what we did, we set out the next study. We were lucky enough to get funding from Tour de Cure to do something called the NEAT PAR study, so participatory action research study with people from culturally and linguistically diverse backgrounds, and said, what do we need to do to this nursing equity assessment tool to make it work for you? How do we make sure that this is culturally safe, culturally sensitive? How do we make sure that it's actually tapping into what matters most to you? And they were very happy with the items on the tool, and I'll show that on the next slide. But what was a real sort of shot across the bows for us is going, you make assumptions about what we know and understand about the system. Most of us, or lots of us, don't understand what Medicare is, how the PBS works, what's the MBS. You know, some of us may have no GP, we don't know how to get to a GP. So it really helped us think about honing the NEAT tool so that it could be something that was of value and meaningful for a much broader community. So we finished that piece of work, and then we're just finishing the NEAT care study, where we have developed a series of co-designed, and all of this, of course, has been co-designed work with people with lived experience. We've co-designed resources for nurses. So Judith, to your point, we need a workforce that can deliver these things, deliver it well. And so we've worked with nurses and patients and carers to think about what would be the educational resources nurses would need to be able to use this confidently, safely, and in a standardised way in practice. And we're just finishing that. And we currently have a grant in called NEAT Start to go, once we've got those resources, can we then test them at scale? And actually, can we start thinking about getting the NEAT as part of usual care? And one of the things that really struck me when I was reading the report last night was that first recommendation about national data. What happens if we can get, and I don't expect you to be able to read that, but what happens if we can get something like the nursing equity assessment tool into routine practice, that we suddenly have a national data set on social determinants of health needs to understand who is getting treatment, who isn't getting treatment, who's getting onto a clinical trial, who's not, who's doing well, who's having the better experiences, and being able to do that with that health equity lens. So our vision for the NEAT work is that every person experiencing a cancer diagnosis has the same opportunity for early and timely assessment of social determinants of health need, that intersectionality we've heard so much about today. If you are impoverished coming into a cancer diagnosis, and the kind of data that we heard about the costs of cancer treatment, you're not going to stay. You won't last, and you certainly won't have the treatment that you need. How do we find people quickly? So the promise for the NEAT is that we use it with every new cancer patient as they come into the system, to think about this equity and equality piece. Who needs the eyes on them quickly? Who needs that extra support around them, the face-to-face stuff? And who are the people who can manage well with referral to the incredible support services that we have out there in the community, so that we're beginning to join the system up for people, and more importantly, beginning to be effective with the resources that we have. We want to make sure that every person who's disadvantaged by social determinants of health needs is prioritised for support. It's not about equality, it's about equity. So that we're prioritising the scarce resources that we have to the people who need them most, and making sure that the people who can self-manage and self-navigate have the pathways and the knowledge and the information to do that. So I just want to take 2 quotes from some of the NEAT work before I go on to talk about another one of the studies. So why ask? This is one of the patients in the NEAT PAR study. When I first came here, I don't know how the Medicare thing worked, because most of the Southeast Asia area, we don't have Medicare system. So they're quite shocked. The patients are quite shocked. Are you sure it's free? Nothing is free in this world. So they just prefer not to get help. So the assumption that we think that people will come in and recognise that there is free help for them needs actually to be unpicked, because we will overlook people and make assumptions for them. Why do we need to ask? So that we avoid making assumptions. And we need to ask because people, as we know, bring all sorts of intersectional problems that may not be apparent to us in the same way that it might be if we're looking at their cancer, impact on their body, or things that we can visibly see. And this person said, you really need to know if that person's safe in their home while being treated, you know. Have they got domestic violence? Just because a person's got a room in a house doesn't mean it's a safe place, especially if you're going through radiotherapy or chemotherapy. We ask because we don't know. And in the last 5 minutes, I want to talk about the PanConnect studies. These have been a series of projects where we've been working with people with pancreatic cancer who are having care in cancer centres where there is not enough resource to have specialist pancreatic cancer nurses. So we started off with a co-design study. We had patients, carers, health service researchers, policymakers, multidisciplinary clinicians as part of a co-design study. And we said, who needs to be doing what, where, for who, for how long, to actually make sure that people who have a diagnosis of a pancreatic cancer get to the support that they need quickly. And we designed something called the PanConnect intervention. It is centralised, nurse-enabled virtual care for people who are cared for in a specialist centre where they have not enough resources for a pancreatic cancer nurse, but the treating team really recognises the value of having that expertise at hand as a value add to the care that's already being given. And so the model, and I'll show you in the next photo, is one where the nurses who sit centrally have honorary contracts with the participating sites, so that that nurse has visibility into the medical record, that they know what's happening to somebody, what treatment they've had recently, are they on a trial, who their treating team is, how to get information back in real time. So that as they collect that information from patient-reported outcome measures, which they use to lead the consultation, there's a real-time loop of information going back to the treating team. We tested its feasibility. We worked with Bendigo Health in Victoria, who are absolutely fantastic, to see, does this work? Can you get the concept of who does what, when and where into practice? And does it work? Is it acceptable? Is it feasible? Is it practicable? And we had some fantastic feasibility data, and I'll read some quotes for you from that in a moment. And now this question of, does it work at scale? We have an MRFF trial where we're working across 7 centres to see, does this kind of model, as a framework for other cancers, and I think could be a really valuable framework for people with rare and less common cancers, where there is no access to specialist nurses. How do we use that kind of model to make sure that somebody rings, and then one of the first things we say is, we need to put you in touch with Rare Cancers Australia, or whatever that might be. And we are actually hoping, we've got a grant in to look at this model with people with early onset colorectal cancer, and are currently working on a grant to look at it more broadly across early onset cancers. So what is it? I've said it's a 12-week intervention where people are referred to the PanConnect nurses. It is a way of quickly finding out what matters most to people, what do they need help with. The nurse rings once a week, but people can ring the nurse at any time. It's a cycle. It's an opportunity to try and go from that 35 years of this complexity of system to start saying, how can we in some small way start joining the dots for people? And we're getting some really hopeful outcomes. So I'm not going to, these look long, but I just want to give you a sense of what we're seeing, both from patient and carer level, but also from a system level. I can't emphasise enough how important it is, the model, because sometimes it feels like a fair while between doctors' appointments and things start happening. And I know you can get on to people quickly by having this service. I think it's absolutely great because it's a minimum of weekly contact and I can contact in between. When you're trying to get hold of a public health system, you can't often quite get to the people you want to talk to, whichever specialist you're dealing with, as quickly as you can when you can pick up the phone to the Pan Connect nurse. And another person said, the best part is being able to realise that you can actually talk at any time during the week. That's the best part of it. Because I got cook on a Friday, this person was in the hospital, they got discharged at 6 o'clock in the morning to go home. They were unwell. They rung the Pan Connect nurse and said, something's not right, I've been sent home, done their bloods. She rung the hospital and said, this isn't okay, and got the person straight back in and got some changes made to treatment decisions. That's the kind of system that we want for people, and it's the kind of system that people deserve. So what are we hoping for Pan Connect and beyond? That we can overcome this inequity of opportunity for optimal management, whether it's pain and symptom management, as we have in the Pan Connect study with pancreatic people, whether it's access to quick supportive care, to exercise physiologists, to dietitians, to social workers, back to oncologists, whatever it may be. That everybody has the same chance for that to happen in a timely way. Because we know from international evidence that when you have that care navigated, not only are your experiences better, your duration of survival is longer, and your outcomes are better. We think it could be a framework for care across the country where we can use these kinds of centralised models to make the most of a workforce. By 2035, we'll be 123,000 nurses short in Australia of the number we need to deliver care. We have to start thinking differently about how we configure care services. And we do think that it could be a catalyst for equitable change. And the fundamentally most important thing about it, it's built by, endorsed by, and advocated for by people with lived experience. And so I want to finish with this challenge that Christine came. She said, what would you say to the many patients, carers and advocates in this room? And I love this quote that comes from Michael Porter in the Harvard Business School. In healthcare, the days of business as usual are over. So if I can challenge you with anything as I leave, take that quote with you. The days of business as usual are over. It is not okay that 35 years later we still have a system that people can't navigate and leaves them feeling uncared for. Thank you.